Hello everyone, my name is Tanner Smita and I am affiliated with the University of Pittsburgh Department of Emergency Medicine. Today we're going to be talking about double sequential external defibrillation, which is a technique that has been suggested to be effective in the treatment of patients that suffer from refractory ventricular fibrillation. And it's generated a lot of buzz in the resuscitation community recently. I thought it would be useful to put together a video documenting some of the clinical evidence that has suggested its usefulness in the setting of out-of-hospital cardiac arrest. Now, we know that out-of-hospital cardiac arrest patients that present initially with a shockable rhythm have a much higher chance of survival than their non-shockable counterparts. In some systems, if a cardiac arrest patient presents initially with ventricular fibrillation, their survival rate can be as high as 30%. And we know how to treat these patients, right? High-quality CPR, rapid defibrillation, epinephrine, antiarrhythmics, amiodarone, lidocaine. And in the majority of these patients will respond well to these interventions. But the problem is a subset of this group, about 10 to 20% of out-of-hospital cardiac arrest patients that present initially in ventricular fibrillation will not respond to these interventions at all. You can shock them as many times as you want, you can fill them with as many gallons of epinephrine as you want, but they're simply not going to respond. They're going to stay in ventricular fibrillation, and as that resuscitation drags on and on, their chance of survival is going to decrease and decrease and decrease, and in the end, the mortality rate for patients that stay in refractory ventricular fibrillation is greater than 90%. And until recently, there really hasn't been any great treatment modality for us to move on to when we've established that the patient is refractory to standard interventions. There have been a couple small emergency department-based trials of using beta blockers in these patients. Excessive beta adrenergic stimulation from exogenous and endogenous catecholamine surges has been shown to decrease cardiac automaticity, and so giving a beta blocker like esmolol is shown to possibly have some benefit. The only other bastion that we have is double sequence external defibrillation, delivering 2 shocks in series from 2 different defibrillators. So standard ACLS guidelines dictate that whenever you defibrillate an out-of-hospital cardiac arrest, you place your pads in the anterior lateral positioning. And so you can see this standard positioning marked by the blue pads labeled number 1 on this graphic. Whenever you decide to engage in double sequence external defibrillation, you grab another defibrillator and you take those pads and you place them in the anterior posterior positioning as displayed on the slide, the red pads marked number 2. And so not only are you delivering 2 shocks in sequence from 2 separate defibrillators, but the shocks are also, the vectors of the shocks are also perpendicular to one another. And so this is very important to why we actually think that double sequence external defibrillation has a greater effect than standard defibrillation on terminating refractory ventricular fibrillation. Now, there's no conclusively agreed upon mechanism that would explain why double sequential external defibrillation has a benefit for refractory ventricular fibrillation patients. But there are several theories that would explain such a benefit. So first, animal studies have demonstrated that whenever a shock fails to terminate ventricular fibrillation, the VFib reinitiates from the portion of the heart that has the lowest voltage or the lowest current gradient. And so whenever you look at standard ACLS pad placement, that anterior lateral placement, the part of the heart that is furthest from the direct line between these 2 pads is the posterior ventricles. And so adding that additional vector, adding the anterior posterior pads, ensures that the greatest current gradient is experienced throughout a greater proportion of the heart. You're preventing the low current gradient in that posterior portion of the ventricles. And this is one theorized benefit that DSED has. In addition, you're just delivering more energy to the heart. You're going to get a greater current density at the myocardium. And because you're delivering defibrillation so closely after one another, you're functionally creating a longer duration defibrillation that could lead to a theorized benefit. Other animal studies have also shown that as resuscitation continues, larger and larger shocks are required to successfully defibrillate a heart. But with double sequence external defibrillation, delivering 2 shocks in quick succession could decrease the threshold needed for successful defibrillation. So that first shock reduces the voltage that's needed for that second shock to restore perfusing rhythm to the heart. Before very recently, all of the evidence we had examining double sequential external defibrillation came from observational studies and isolated case series published over decades in the literature. And so on this slide, I have listed as many of these studies as I could find, indexed on PubMed. And if you're interested in this topic, I do recommend that you go and hunt down each individual study and read through them. Gives a great window into, why people think this may have a benefit for treating refractory VFib, how this has been implemented in different EMS systems. However, all of this evidence, all of this retrospective data is very low quality and really cannot provide any basis for either implementing this method in the field or making the decision to not implement it in the field. And so for one, again, like I said, it's all retrospective data or case studies with an N of 1 or very low N's. So no causation can be inferred. Second, the definition of refractory ventricular fibrillation is inconsistent between many of these studies. Some say that it's ventricular fibrillation that continues to recur after 3 shocks. Some say 5, some say 3 with epinephrine and amiodarone. Some don't worry about the drugs in the definition. So there's a lot of inconsistency and differences in definition that make it difficult to compare outcomes between some of these studies. Finally, and perhaps most importantly, in these studies, it seems that double sequential external defibrillation is used overwhelmingly as a rescue intervention. And so, it's being used on patients as a last resort. CPR has been done for 20, 30 minutes. They've been shocked 6 or 7 times, right? They have tons of epinephrine flowing through their veins. These people are globally ischemic. Many of them are already brain dead and have no chance of survival. And so, using their cases in order to determine whether or not DSED can be used to improve neurological outcomes or survival to hospital discharge for these patients is a bit foolhardy, I feel. Thankfully, this year, a Canadian team published the DOSE-VF pilot randomized controlled trial, which gave us the first gold standard data that we can really use to evaluate this problem. And so this trial evaluated 3 different defibrillation techniques that can be used to manage patients in refractory VFib, which was defined for the purposes of this trial as VFib that's refractory to 3 standard defibrillation attempts. 152 patients that met these criteria were randomized, cluster randomized, to 3 treatment arms. So the first arm was standard therapy. The second arm was vector change defibrillation, which just entailed paramedics on scene changing their pad placement from the anterior lateral placement to the anterior posterior placement, switching the vectors there. And then the third arm was double sequential external defibrillation, which was carried out exactly as depicted in that graphic shown earlier in this video. And so the primary outcome reported in this trial was the safety and feasibility of studying these defibrillation techniques in out-of-hospital cardiac arrest. And on that front, they passed with flying colors, right? It set the stage for a much larger trial that we'll be seeing the results for here in a few years. But what generated a lot of the buzz in the resuscitation community and all the excitement was the secondary outcomes that were reported, including termination of VF in the field, return of spontaneous circulation in the field, and return of spontaneous circulation at ED arrival for each of the treatment arms. And so the results showed that for the vector change group and the double sequential external defibrillation group, in terms of termination of VF and ROSC in the field, they blew the standard therapy out of the water. Right? And you can see from this table here, there's no statistically significant difference between the vector change and DSED groups. But they're very clearly higher than the standard therapy. They're getting much better numbers. In terms of ROSC at ED arrival, DSED is the clear winner with 32.7% of patients treated using this method having a pulse at emergency department arrival. However, these results should be interpreted with caution. And I think the main reason for this is the fact that these outcomes are not patient-centered. And what I mean by this is we're not really sure of the effect these interventions had on patients' actual lives, right? It's fantastic that they had VF terminated in the field. It's fantastic that they had ROSC as they pulled into the emergency department. But we don't know if these patients went into the ICU and then crashed after 2 days. We don't know how many people were discharged with a neurologically intact CPC score. And so if these endpoints are not met, if we're not seeing any survivors discharged, it may not warrant implementing this resource-intensive intervention in the field. And so we have to be really cautious whenever interpreting this early data. And so in conclusion, the relevance of this data to clinical practice remains to be seen. We need to see more patient-centered outcome data before we can make any kind of a determination, and for example, before ACLS can start incorporating DSED into its algorithms. But with that said, this certainly generated a lot of enthusiasm in a lot of people. It certainly excited me. And I'll tell you, if tomorrow I came across a cardiac arrest patient and they were refractory to 2 or 3 shocks, I would certainly think about calling another unit to bring a second defibrillator to the scene. And while they're en route, I would definitely consider switching the vectors of my pads. With that said, that's all I have for you today. Thank you very much for listening.